I'm correct. Give me a second. Is it citizen scientist mixed met study and AI software for qualitative data analysis? Awesome. All right.
Yeah.
We should be good to go. You can start whenever you're ready. Thank you all for being here.
Great, thanks a lot. Then I suggest I make a quick intro, and actually Mamaswatsi and Malena will then take it over. Yes, so very nice being here. Thank you very much for this invite. It's really a pleasure to present. We are quite a diverse group from a bit all over in this research project. It was funded by the Citizen Science Foundation in Switzerland. So a foundation that specifically wants to promote citizen science research, and that's what you will see in the presentation as well. It has quite a citizen science approach to it. We are a research group or research consortium, partly based in Basel, Switzerland. That's where Malena and myself are based, with collaborators in Lesotho, Southern Africa, who I see are also on the call behind Mary and the hub. So Mary coordinated the local implementation in Lesotho. Great that you could join as well. And then very important collaborator and contribution from the George Washington University with Mamaswatsi, PhD student there, with Professor Conserve, who I see is also on the call. So really nice that you could all make it. I'm looking forward to the discussion. And then I'd say I hand it over to Malena, who will give a first talk, and then Mamaswatsi.
Thank you, Alan. Hello, everybody. So I'll start with an overview of the project, so then Mamaswatsi can focus on the AI qualitative analysis. So to begin with, our study took place in Lesotho, where 1 in 4 adults live with HIV. There we are with the map of Lesotho and some statistics about HIV. So also 2/3 of new HIV cases occur in young women. In fact, HIV and pregnancy complications are the leading causes of death in this population. So there's a challenge in Lesotho. Although HIV care is available, there are certain barriers that prevent the population to accessing them, especially young women. These barriers are related to a lower risk perception of HIV acquisition, related to gender dynamics, stigma, etc. It's been also shown that integrating HIV with other sexual and reproductive health services could address the needs of this population. So this is why we believe that maybe more accessible and demedicalized community care models might address this issue. And this is where hair salons come in. But why hair salons? So in Lesotho, this is a relevant community space where women spend a considerable amount of time. They go there very frequently, and they build relationships, especially with the stylists, who are trusted members of the community. So this is why we came with our study, in which we assessed the acceptability and feasibility of offering HIV and sexual and reproductive health services at hair salons in Lesotho. For this, we evaluated several services, for example, HIV counseling or contraceptive pills distribution, condom distribution, etc. So it was a mixed method study. We begin with a cross-sectional survey. This was done online and at a nationwide level. And this was followed by in-depth interviews that were analyzed, supported with AI using rapid thematic analysis. And also we wanted to highlight that the different stages of the project were co-developed with local stylists and clients. In fact, here in the next slides, we can see some pictures from the workshops in which stylists and clients were working in refining the data collection tools. In the following picture, we see they were testing the surveys in their cell phones. So we can continue with next slide. Our population was composed by two groups. So we included stylists of female hair salons and also clients who identify themselves as women between 15 and 35 years old. So the recruitment began with a web page that the hub, our local partner, developed. This web page was distributed through social media, through influencers, also the radio. So stylists would get in and register. They would send us some personal information, some GPS data, also pictures from the salon. And then we would do this data checking in which we would assess if there were some duplicates or fake data. And if everything was correct, then we would send the stylist a link with the actual survey. They would fill it in. And after we receive it back, we will ask them to recruit up to 3 clients. So now again, the clients would register with all of the personal data and pictures. We would check this data. And after this, clients would receive a new link with the survey. And after the process is done, we would reimburse clients and stylists. The next one, please. So we got 157 stylists with a median age of 29. The majority of them were women. And we also had 308 clients with a median age of 26. And here we can see in the map that the participating hair salons were from all of the 10 districts of Lesotho, but the majority of them were located near cities, mostly around Maseru, which is the capital city. And here we can see some pictures from the salons that the stylists sent us, so we can see how diverse these spaces look like. There's another slide with some pictures. So we asked in the survey, we asked the stylist in blue and the clients in red how comfortable they would feel to offer or to receive different HIV and sexual and other sexual and reproductive health services in the salon. Here we can see the results for the HIV related services. So we have HIV counseling, HIV self-testing, pre-exposure prophylaxis and post-exposure prophylaxis. And here we can see that the answers are quite high. Then we also ask the clients in this case, would you be interested in receiving each of these services in the next 6 months in the hair salon? So this was a question to assess the potential demand for these services. And we see that for these 4 services, the answers ranged between 15 and 30%. Another question we asked the stylist is if they thought that this would impact their business either positively or negatively. And in the majority, 90% of the cases, they said that they believe this may have a positive impact. But what happened with the participants that said that they would not feel comfortable with this? So here we have a quote from a client to illustrate of one of the interviews to illustrate that the main barrier that we have is that there were some concerns regarding privacy. So for example, here this client says that you need someone who's very discreet to treat these topics, like for example, PrEP and HIV. We also have some information on the salon characteristics. So we saw that they were mostly open 7 days a week. Only 21% of them have an extra confidential space. And alternatively, the majority have a toilet on site. Also regarding the clients' visits to the salon, they used to go there once a month or more and spend 1 to 4 hours there. Also, the travel time to the salon was usually less than 30 minutes. And here we have one quote, again from one of the clients, in which she says that the emergency contraceptive pill would be better to obtain at the salon. So here also in the qualitative, we found as long as, I mean, in the survey and in the interviews, we found that salons seems to be a little bit more accessible in terms of cost and time than the nearest healthcare facilities. And we have also here another quote, in this case from a stylist, in which they say, I think the salon would provide a safe space. So this theme also appeared in the interviews. So the salons were seen as a safe, non-judgmental community spaces to talk about these topics. So to conclude, offering HIV and sexual and reproductive health services in hair salons in Lesotho seems to be largely acceptable and feasible, only if confidentiality concerns are addressed. We also observe that the salons are considered community safe spaces, and we will need to continue with this project, doing a pilot to see how this approach works in practice. So yes, that was all for the overview of the project. I will now hand it over to Mamaswatsi for the AI-supported qualitative analysis.
Thank you, Malena. And I'm sorry, I feel like I rushed you at some point, but thank you. And I'm also noting the questions in the chat. We'll address questions at the end of the presentation. Hello again, everyone. As Malena said, my name is Mamaswatsi, and I'll be zooming in a bit on the process of using natural language processing to support our qualitative analysis, which is very exciting. Okay, at a glance, this is what the process is going to look like, but I will break it down a bit and give more detail. And so this process consisted of developing domains or categories for analysis. This was followed by developing prompts that we would feed into the natural language processing software. And then afterwards, we tested whether the prompts that we were using were actually reliable and if they were actually capturing the data that we wanted them to capture. And then after this, we developed an analysis matrix, which the research team relied on to build themes and conclusions for the study. So I will go into a bit of detail for how exactly we did this. Okay, so the first step, developing the domains or categories. In traditional manual or human qualitative research, you can develop the domains that you need for your research through various methods. One of those could be from existing literature. You can use that existing literature to figure out generally what are the broader domains that I need in order to code this transcript. You could also use your interview guide to get to some of those domains or categories. What are the broader categories that can help me analyze this transcript and to answer my research question? Or you could also use a theoretical framework. For example, if you wanted to use the health belief model, maybe your domains would consist of perceived barriers, perceived benefits, cues to action. And these are larger categories that you're using to get an understanding of your data and to help you analyze your data. And in our case, we used a mix of the interview guide and the existing literature, and we're interested in what are some of those barriers and facilitators to potentially accessing the services at the hair salon space. Okay, when we had developed the domains that we are interested in, primarily barriers to accessing services at the salon, concerns or facilitators to accessing services at the salon, we developed prompts. These prompts are the instructions that we're going to feed into the natural language processing software. And so the first prompt that we developed, we are asking the AI to summarize the transcript based on those domains that we developed from the previous step. And so then you feed that instruction into the AI, you also feed in your transcript, and it gives you a summary. The second prompt that we used was to pull illustrative codes verbatim based on the domains. So the same domains that you asked for summaries for earlier, then you ask for codes that are going to support those summaries that you had initially gotten. And then the third prompt that you're going to develop is going to get more into the inductive coding of your transcript. And so here you ask for illustrative codes on other related topics, and you provide it with keywords that you're interested in that relate to your research question. So yeah, just to review, first you develop the domains that you're interested in, the broad categories that you're interested in, and then you develop prompts, which are the instructions that you're going to feed in to your AI software. And so this is what it looked like on our end. We used a software called AvidNode for our particular research. And it is like a toolbox that is specifically designed for research. And it has an option where you can code your interview. If you can look at that, the first red box, you can code your interview, but you tell it how you want your interview to be coded. And so then you put in your transcript into the software, and then you give it the prompts. And so we ran one prompt at a time. The first prompt was summarize this transcript based on those domains. After getting the output, the second prompt was give us codes based on those domains. And so this is what it looks like with a sample transcript. This is not an interview with anyone. Don't worry, Sarah does not exist. This is just a generated sample transcript that I ran for this particular presentation to show you what it looks like. And so if you'll see on the right-hand side, first I have the transcript that I just copy-pasted into the software. And then if you see the next box is where I put in the first prompt. And so here I was using the health belief model, and I'm asking the AI to summarize this particular transcript based on the domains of perceived benefits of adhering to medication, perceived barriers to adhering, and cues to action. And you will see that as I move away from my left to my right, that is the output that I got from the AI. And so they tell me in terms of perceived benefits of adherence, this is what the participants said. They talked about routine integration, they talked about having a sense of control, and they talked about the importance of a support network. In terms of perceived barriers to adherence, this is what the participant talked about. And so these are summaries that are generated based on the transcript that you gave to the AI. And so once you have this transcript, the next step will be to put it into an analysis matrix that we will also take a look at. But as part of that, you also want to make sure that the output that you're getting from your software is actually reliable and it can be trusted, which is also a normal process of assessing the rigor and quality of qualitative work. One of the steps that we took to ensure that the coding was actually reliable was that we took one transcript at random, which one member of the research team analyzed alongside the AI, and then we compared the analysis that was done by the AI versus the human being. And then that was followed by reconciliation, where we then changed or adjusted the prompts that we fed into the AI to more accurately reflect what we were looking for. So as an example, when we did the first round, we had asked for barriers and facilitators to the intervention. And then we realized that the AI had picked up on any word that had any phrase that had the word barrier or facilitator, but had not really grasped that we are looking for advantages, disadvantages, concerns, challenges. And so part of that reconciliation was revising that instruction to more accurately mirror what we wanted out of the data analysis. Another step that we took, I need to take a breath. Another step that we took was running one prompt multiple times with one chosen transcript. And so we ran it 3 times, and then we pasted the output into an Excel sheet so that we could see what is the output at each iteration. How do the different outputs differ? Is the output actually dependable? And what we found was that the results are actually consistent. Although the summaries were not word for word, the content that had been summarized were the same for one transcript that was done with one prompt multiple times. Another very reliable method that is widely used in qualitative research is member checking your results. Once you have your output, checking it with other members of the research team that were not necessarily doing the analysis, so that you ensure that the results that you have are consistent with how participants feel and what is to be expected. This one is very important for AI research and one that folks have also been worried about a lot. AI hallucinations, were any of the codes made up? In our experience, we found that none of the codes were made up. So once it identified the quotes verbatim, we went back to the original transcript to verify that the quotes that had been identified did actually exist. And so this is probably a step that you want to include to make sure that your model is not bringing in any false data. And so the output we transferred into an analysis matrix. This is what it looks like, where we have the different domains. They form the sheet, the tabs at the very bottom of your Excel sheet. The first tab is domain 1. If you can see the very bottom of the screen, involvement in the research process. The second domain is the current knowledge and uptake of sexual and reproductive health. The third domain is facilitators. The fourth is barriers. And then the fifth is where we're doing inductive coding of any other related topics. And so within each sheet, we have the participant ID, very important that you have de-identified data. And then you have the key point and the code. So you include a code that you output from prompt 2, and the researcher comes back and gives a summary of what the code was saying. What is the key point based on this code? And then in column C is the summaries, and these summaries are from prompt 1. So if you can remember, the first prompt asks for the summaries, and those will be in column C. And then the second prompt asks for illustrative codes that support that summary, and those will be in column B. And then remember to put in the participant ID. So then what happens is that once you've populated the entire analysis matrix, all your participants, as well as across all the 5 domains, then the research team comes back to the analysis matrix in order to develop themes or conclusions to interpret your data and answer your research question. And so this slide may be repetitive for folks that are familiar with qualitative research, but just as a reminder, even though it is rapid thematic analysis, as you develop your themes, as you develop your conclusions, to remember that the themes cut across multiple domains. You're not necessarily just going to give a summary of each domain to say that is a theme. In terms of building a theme, you focus on the ideas that are prevalent among your participants, but you also talk about ideas that may stand out or may be different from other participants. Your themes also, it's important that they answer your research question or attempt to answer your research question. And also to remember that your themes and your conclusions can be presented in many ways. In traditional thematic analysis, we typically have a full sentence that explains your theme, but you could also use a diagram to represent your data and then have some accompanying text and quotes. And so the way we decided to present it was that we developed a sunburst where you can see that the different shades of purple are the clients and the client's perspectives, whereas the green is the stylist. And so I'll try to go for the biggest one so that it's less difficult to read. For example, you see that among clients and the barriers that clients faced, one that seemed to be prevalent was that stylists may share personal information with other people, which is the barrier about confidentiality that some folks in the chat were already talking about. This is something that makes it difficult for clients to want to access the services from their stylist. Yeah. And so that was the process of using natural language processing to use rapid thematic analysis in this paper. And I've included here some of my own reflections from this process, as well as the reflections that we had as a team. The first one was realizing that it's important to use non-technical terms as you're communicating with the AI and giving it instructions. And so an example is that one where we had asked for barriers and facilitators, but because it's a large language model, it's pulling words that are associated with barriers and facilitators, so it may not be as accurate. Whereas if you're talking to it as though you're talking to a sixth grader, you're asking for what are the concerns that this participant has about accessing services at the salon, you're more likely to get information related to your barriers. Another reflection that I had was that it's very important to keep a thorough audit trail. So every time I developed the prompt, I kept an audit trail with a date, like on this date, me and this member of the team developed this particular prompt that we ran. And each time that we as a team decided to change the wording, we then updated our audit trail to keep track. This is particularly important because, as you're aware, with qualitative research, it's very iterative. You're probably going to want to go back and recode the same interview. And so if you keep a record of which prompts you're using for your AI, you're more likely to be consistent and consistently use the same prompt. What was it? I found second line coding a bit challenging though with this process because just asking for categories and domains was very straightforward. But then thinking about how do I go from these domains and the summaries to tying the different categories together and seeing how they relate with each other, that I found a bit more challenging with natural language processing. And that's where me and members of the team read through the analysis matrix to then build those conclusions that we used. I did usually I find it's usually a labor of love when I realize that there's some domains or codes that I hadn't thought about. I'm on transcript 5. I've already coded through 4 transcripts and now I have to go back and recode. It's usually a painful process, but I found it a lot more streamlined to then just go to the transcript and repeat the new prompts without having to manually go through the whole process by myself. Yes, I believe that's it from us. We're happy to answer any questions that you may have, and thank you again for having us.
It is
Thank you.
great. Thank you all for the presentation. It was really good to get to know a little bit more about the project. We had a lot of questions in the chat. Maybe we can start with those. People really liked the work, but so the first topic is like Obali talking about the confidentiality being a big issue for HIV care. Obali, would you like to expand on that? Maybe I'm not sure if you had a specific question for that topic.
Yeah, it was just kind of a comment. I remember working with folks who are HIV positive some years back, and the major issue seems to be confidentiality. And I don't understand how the context of South Africa is, but in the context of Cameroon, the hair salon will be one of those areas you don't even want to take topics like this into. So I was kind of wondering how you guys managed that.
Okay, I can touch a bit on this, and then the next question I'll give to my colleagues as well. And so we did find that in terms of the survey responses, people were a bit more comfortable with services that are not related to HIV, accessing them at the salon, as opposed to HIV-related services. But the acceptability was still high in both. It's just with HIV-related services, it was slightly lower. And then with qualitative interviews where we're actually asking people what they thought, confidentiality was a big concern for them. But we did find that salon spaces and a hairstylist was almost a double-edged sword because they liked that they have a close relationship with that stylist, and that at hair salons, people talk about issues such as sex, people talk about sexual health. And so that was already, an encouraging factor to seek those services, though some participants were a bit hesitant in terms of HIV specifically and being concerned about the stigma associated with that. I don't know if, yes, my colleagues would like to add on to that.
maybe just to add one sentence there. I mean, Mamaswatsi explained it very well. That's exactly the experience we had. So it is a confidential space in one sense, right? Where women really talk about everything, and we had a lot of positive responses. But one has to be a bit careful not to also, not to destroy this trust that is available in a hair salon, and that depends a lot how far one wants to go. So certain products, certain discussions, certain services were no problem, while other services were a bit more. There was a bit more discussion. So in one sense, it is actually a very confidential space already, and more confidential than, say, at the clinic, where people do not like to talk about sex. So you can argue both sides. The other thing maybe to mention is that it also depends a bit how you then offer these services. So there are different models, right? You could think of the hairstylist introducing the discussion, starting talking about HIV prevention products, but then referring to a nurse in the back room or to the clinic. So, right, it also then really depends how far you want to take this model, and that would need more investigation and probably a pilot to really check how far do people want to go, what's the comfortability level and the demand. Yes, it's an important question. And I think it touches also on the question that Edwin had, right? It's a bit the same about privacy being a big barrier. I think that touches on that question as well.
Definitely. Yeah. Thank you for that. Then I had a question, and Edwin also followed up on the actual AI approach on using the I forgot the name of the website just now, but using the NLP or the LLMs to help with the qualitative analysis. We wondered how does it work in terms of the selection of the model behind? Do you select based on if it's free or if it's paid, or how good it is, and also how much the identification needs to be done? And an additional question is, did you have any issues specifying this type of analysis through like the IRB approval or the ethics committee or something? Was that any challenge at all when you were proposing this?
Maybe I can start with the more boring legal, but then Mamaswatsi can talk about the identification of the transcripts. So we chose AvidNote, and AvidNote has its own proprietary AI model, which and we chose it because AvidNote is completely GDPR conform. So GDPR is the European data protection law. Not sure how it's called in the US, but that's kind of the highest standard of data privacy. And they store everything on servers in Sweden. It's from the University of Stockholm originally. So that's why it's from the research community, and it is GDPR conform. And this we also wrote into our ethics application, and actually we didn't get any issues with that. They didn't have any follow-up questions. But that means, of course, it's paid. So we did pay. We had a license. It was not too much. We got kind of a research discount and shared across with other research groups, but it's not for free. I'm not so sure about performance. It's likely that other LLMs would perform better. They just say they have kind of the best specifically trained AI model for research. So they trained all their model on legally accessible research data sets, but we can't give you kind of a comparison between different LLMs because we only used that one. But we did not paste anything into ChatGPT. Any transcripts was really just through AvidNote. But maybe Mamaswatsi can follow up on what did you actually do to the transcripts.
Yes, so the transcripts we used were fully de-identified. So for our case, the interviews were done in a mix of Sesotho and English. And so then members of the research team translated those manually, and then de-identified the transcripts, and the transcripts that we fed into the AI were de-identified.
Awesome. That's really good to know. And Anna added the link to the Avid note there. It's good to see that at least from browsing, it seems that they have already partners from the US already using this. So we might also try this in the future. So thank you. Let me see other questions. So Rafael asks if you considered other places like nail salons, and where there has been usually has the risk of HIV contamination due to using the same nail clippers, etc. Was that part of the project as well, or not?
So
Should I?
from the very beginning, yeah, but anyway, I will ask for your input also, Mamaswatsi. From the very beginning, the idea was to assess these at hair salons because they are really culturally relevant community spaces, but maybe Mamaswatsi can provide some local insights.
Yeah, thank you, Malena. Yes, that was the idea was hair salons. For a bit of context as well, a lot of times nail stations may also be housed in hair salons. So it may be like a hair salon where there's stations for individuals who do nails or other beauty services. So that's a bit of context. But yes, our idea from the beginning was hair salons, and we're hoping that in future we can also branch into spaces such as barber shops that also have a very culturally relevant safe space. Yeah.
Got it. Got it. Thank you. And now I wanted to open for the room to see if other folks have questions, if they wanted to clarify anything for the project.
I have a quick question. Hi, my name's Natasha. I'm a first-year Master of Global Health student, and thank you guys for presenting. It was a really fantastic presentation and seems like a really exciting project. I guess mine's a little bit less of a question and more of an idea, but have you thought about kind of identifying people who work in salons as essentially like safe people? Because I think we could assume that maybe not every single provider will be open to this idea, but that certain ones might be particularly receptive to it, and especially when we're thinking about like HIV patients, where that ends up being like a little bit more of a sensitive topic, maybe finding some way to identify like who are the providers that are particularly safe people that are more likely to maintain that confidentiality and, providing those services.
Should I go first? Mamaswatsi, Malena. I mean, it's an interesting idea. I'm not so sure how you would identify and define a safe person. I think, and because a lot of it is about trust, right? So clients feel comfortable at a hair salon, talk about a lot. Might be because this person is just has a very good social interaction, but it might also be a very gossipy person, and maybe in terms of confidentiality and privacy, maybe not, but is a very sociable person and people feel safe. So I think I would have a hard time to identify safe stylists, but of course, what we will have to, or what we would think of if in a pilot is training. So I think you can make people safer, or at least try to. So I wouldn't like we would not start this project and just take anyone and then just say, okay, now you talk about this and you give out some, I don't know, some HIV self-tests, but you would involve a proper training, and there you talk about confidentiality issues and referral, and there maybe there during the trainings you could realize or identify some people that are not comfortable with doing that, or who maybe you could include a little test. Yeah, so I think maybe as part of the training, it's definitely an important aspect and one has to consider. But we never discussed like defining a safe person from the onset, right? Mamaswatsi, I think that was, how do we define a safe stylist? But I think training is key.
I agree. And I think maybe in some interviews as well, some clients and stylists alluded to that. Like, how do we know that this person is credible, or this place that I'm getting this information is credible? And one stylist suggested maybe after training, providing a certification, just so that the clients know that I have been trained to provide this information and I can keep your information safe. Yeah.
Got it. Thank you. Any other questions, folks? Maybe also for the presenters, did you have anything that you wanted to talk in particular, or any follow-up that you are interested on? Any partnerships after this meeting that maybe we can do via email or something?
I mean, if anyone is working in a similar space, of course, that would be of interest. I know you are doing a lot of global health projects. Of course, that would be always interesting to reach out and collaborate. Yeah, so to any one of us, any of the emails that you have.
Perfect. All right. So thank you again, everyone for joining. Thank you, Alan. Thank you, Malena and Mamaswatsi, for being here and presenting to us. You are more than welcome to come again and present and just listen for the other sessions as well. We are always open